There's the vascular spider, and there's the Venus star. All right. Moving on. Assessment of the integumentary system. You don't need to do anything with that 4. I meant to erase it. It's physical assessment, talking about the nails. It's shape and contour, the consistency, the color, thickness, and cleanliness. So here is normal. They should be smooth and rounded. The nail surface flat in the center, slightly curved downward. The adjacent skin is intact with no inflammation. Light-skinned individuals, it blanches with pressure. Dark-skinned, yellow or brown, and may have some vertical bands, which are all normal. Abnormal findings would be edema or erythema. These are some crazy words. Kolinkaia, I can't remember anyway, it's spoon nail. I don't think anybody knows how to pronounce that. Leukonchia, that is white nails, white spots. There's clubbing. Look at, we're going to look at pictures of clubbing. Look at Beau's lines too in your slides. Pitting, we have a picture of that. On oncholysis, that is in fungal infection. All right. So here's looking at, oh, not great. Okay, looking at nail of a dark-skinned individual. That is totally normal. You can see the dark bands. Normal finding. This is the spooning of the nail. That is usually a vitamin deficiency. Clubbing of the nail. You see how the nails are going outward. And we'll look at another picture in a second. Nobody knows exactly why this happens, but it's typically in people that have respiratory or cardiac disease long-standing, not like one event, but they over a period of time have those diseases, and it causes clubbing of the nail. There it is right there. You can see it in the center. And that's exactly what it looks like. Sometimes, like I said, usually long-standing respiratory or cardiac disease, some kind of flow and oxygen problem. Okay, so splinter hemorrhages is something we want to look at. Those are abnormalities for sure. So a couple weeks ago, I was supposed to go walking with my girlfriend, and she called me and said she couldn't go. She got an appointment with a physician that day for her nail. I was like, well, let me see your picture of your nail. So anyway, she had fingernail polish on for several months, took it off, and this is what she found. As she wrote on there, I am gross to me. At any rate, see how that's an abnormal finding? Yes, so they took it off, hoping it grows back normally. But they're also were looking to see what could be under there. Is there any type of melanoma? Because sometimes melanoma shows itself in the nail. So if a patient has a black or brown or any kind of abnormal new spot, that doesn't mean go home and diagnose yourself with melanoma if you have white spots on your nails. Lots of people have those from trauma. But if it's really typically a darker colored spot under the nail or something like this, you want to get and look, make sure it's nothing but maybe just damage. She didn't recall any damage to that nail. That's why it was so concerning. Okay. So how are we going to document our findings? This is just a sample documentation. It is very important you know how to write out your findings. Being a newer nurse, everything you do will pretty much be on a computer, but sometimes the computer goes down, and you have to know how to write out what you found. So here is a sample of what you could write. The skin is warm, dry, pink. Turgor is brisk, and the skin is elastic. Or the skin is rough, thickened over the heels, elbows, and knees. Otherwise, skin is smooth. You're describing what you're finding here. There's a 0.5 centimeter yellow pustule on the right shoulder and a 4.5 centimeter scar on the right knee. There are multiple striae throughout the lower abdomen. The hair is brown with female distribution. It's soft texture. The nails are smooth, rounded, and manicured. So you need to know how to write exactly what you have found. All right. Let's see. Also, your Jarvis book, it was not a required textbook, but I would highly recommend you get it. You don't have to get the latest edition. That would be helpful. You can find the older editions much cheaper, I'm sure, on eBay or Amazon or whatever. But you need to have that book, and you're going to need to keep it with you all throughout your clinicals, because going forward, each time you check off in a simulation here, you're expected to be able to chart your findings in 2103, and then as you move on next semester at A&S, from the first day, you're going to be expected to be able to document all your findings. So while you're new at this, you're going to be learning to find new words. So make sure that book is with you, and you can pull it out, and it'll help you document your findings. All right. Here is the process of wound healing. There is primary intention, which means the edges are well approximated. Well approximated means they're lining up. They're lining up beautifully beside each other. If it heals by a first primary intention, the risk for infection is low. The redness is usually gone in 24 hours. Okay, wound that is closed, such as a surgical wound with sutures or staples, it heals quickly, minimal scar formation. There's a picture of primary intention. I'll show you another picture in a second. Here's secondary intention. Typically comes from a burn, like a pressure ulcer, also a pressure ulcer, or a severe laceration. It takes longer to heal. The infection risk is greater. The wound edges are not well approximated. Let's see. Here's a picture of that. That's going to leave a scar. Tertiary intention. The wound is usually left open for several days. Then the wound edges are approximated later. Wounds that are contaminated and require observation for several days. Sometimes even in the hospital setting, they'll go in to do something with the wound, clean it out or whatever, and they can't close it back up because they need to get the rest of the infection to get out. So they'll leave it open on the unit. And you may run into that in 2103. I hope you do. I hope you don't for the patient, but I hope you do so you can see what it looks like. And typically that will leave a scar as well. So a friend came over. I've had a lot of stuff going on the last couple of weeks with a friend. He had cut his elbow on a mirror, sliced it wide open. So he came over for me to remove the stitches. Oh, excuse me, there's tertiary intention. Here's a nice, you can see this primary, I took his sutures out, and then you can see how nice it's healed. Now it's still a little red, which it should be, but that's not a red like infection. That's a pink like new kind of tissue. So the wound edges, see how they're lined up beautifully? It'll heal nicely. Now there are, you can see there were 5 sutures I had to remove. Whoever put that in used big, thick suture wire, so it is going to leave a nice scar. If you go to somebody like a plastic surgeon, they use little tiny thin wire and it doesn't, or thread, and it doesn't leave quite such a scar. But anyway, point is, this is healed by primary intention. The edges are nice and well approximated. All right, so what happens if that doesn't happen? And now we have complications of wound healing. Here are some complications. There's hemorrhage, there's infection in the wound, dehiscence, evisceration, and then hopefully not a fistula formation. Okay, so here is a slide of what that is, those terms. I'm going to show you pictures in a second. But obviously hemorrhage, it's bleeding more than it should. The infection could be dehiscence. That is bursting open or splitting along natural or sutured lines. They have sutured our patient back together or stapled our patient back together, and then it opens and tissue comes out. Evisceration is viscera, the internal organs. Typically this happens in the abdominal cavity. The whole organ is coming out. That's a big problem, right? And fistula, this is a abnormal tunnel has happened. Connects an abscess, a cavity. Sometimes women, as they age, the vagina and the rectum, they'll get a fistula in there because it's just a very thin wall separating the two. And then they'll start having stool coming off their vagina, which is not good. Gotta get that fixed. Okay, so here's pictures. Not great pictures of the dehiscence, but you can see that was a sutured line and it pulled open, and now there's some tissue coming out. Evisceration, obviously that's not good. That's the patient's bowel coming out. So that is a surgical emergency. That is when you would call somebody right away, both of these actually, to come up and take a peek at it and get it fixed up. So what happens, wound healing, what affects it? Age, of course, the older the people are, they may not heal as well. Circulation, oxygenation. Nutrition status, people that are malnourished are not going to heal as well. The wound condition, obviously tertiary or a lot of infection in the wound, they're not going to heal as well. And their overall health status. People that are diabetics may not heal as well. And other chronic conditions, they may not heal as well as they should. All right, we're going to talk about pressure, injury, and staging. Make sure you know this. Look through this well. This is a huge nursing thing. When a patient comes into the hospital now, it depends on where you work. 2 nurses have to look over their skin and document what they see. And I mean everything. Tattoos, if they have any type of laceration, excoriation, abrasion, anything, 2 nurses have to look them over because It costs the hospital a fortune if we fail to document a wound they have and they're discharged with a wound. It looks like they got it on our clock. It's a lot of money. The Medicaid, Medicare won't pay for the wound care for that. So if our patient comes in with a pressure injury or potential for pressure injury, we have got to document that, or the hospital's not going to get paid, and then they're going to be looking for you. So at any rate, wound injuries or pressure injuries cost a ton of money. They take so long to heal. They shouldn't happen. They're 100% preventable if we turn our patients well, if we provide the right barriers. So anyway, something you will learn to know very well in order to avoid it for our patients, not just for money, but because they hurt. So we want to make sure we avoid this. Okay, so stage 1, the skin is intact with a non-blanchable redness. Usually over a bony prominence, mean over the hip, over the sacrum, over the heels, usually over some place that is sitting on the bed or sitting on the wheelchair or whatever. Color may differ a little bit. It may be painful, firm or soft, warmer or cooler. Stage 1, sometimes harder to tell with darker skinned patients. All right, so this is it to help you learn if you're a visual learner on an apple. Okay, so stage 2. Now we have partial thickness of the dermis presenting as a shallow open ulcer with a pink wound bed. There's no sloughing there. Also may present as an intact or open or ruptured serum filled blister. And what is that called? Remember our 4 choices of wound exudate? That is serous. Okay, so that's stage 2. Then we get to stage 3. Now we have full thickness tissue loss. The subcutaneous fat may be visible, but you can't see the bone, tendon, or muscles. Slough may be present, but it does not obscure the depth of the tissue loss.